So now you're going to look at another data source that you can supplement PDE data, and that's a plan characteristics file. So uh, originally, plan characteristics file was really for Part D. So data between 2006 and 2014, so it called as a Part D plan characteristics file, and that included information only on Part D plans. But now since 2015, the plan characteristics file includes information on both Part C Medicare Advantage plans and Part D plans. And then we have now indicator that says a Part CD indicator. So if it's 2, then you can select only Part D only plans. And then if you say Part C PTCD indicator equals 3 means that it's Part C and Part D plans, and you can select the plans that you want to look at. So what is a plan characteristics file? And plan characteristics file includes information about plan type and benefit design and premium and cost sharing and service areas of plans. So again, this is a separate file you have to request. So you have to check, okay, I want plan characteristics file. So before you request, think about what you want to do with the plan characteristics file, and this file is necessary for your research or not. So using plan characteristics file, you can examine, the enrollment characteristics by plan type. In other words, it's simply just the MAPD versus a PDP. That's the first step. And who are in, MAPDs and who are in PDPs, or and all the things that we discussed so far, like medication utilization. Let's suppose you constructed the NPR measure or PDC measure and Sovaldi use, for example, and do they really differ across the different types of plans, right? So first, the MAPD versus the PDP, but within MAPD, so you have HMOs, you have a PDPs. I know that's Part C plan characteristics, but still you will see some variation depending on plan type. And also, of course, the benefit scheme, right? So the Part D has a standard benefit schemes that move through deductible through, 25 co-insurance, which is initial coverage period, and all the way through coverage, catastrophic coverage. However, Part D plans are allowed to modify benefit schemes. So some plans did remove deductibles. So then, if plans do not have deductibles, enrollees in those plans, are they more likely to take more medications or improve medication adherence? And the same as the cost, right? I mean, what types of plans actually have a larger Part D drug cost? So you can examine those things. And also, if you're really interested in the some plan choice model, I mean, who choose what type of plans, right? So in other words, what plan characteristics are determinants of plan choice, the beneficiary's plan choice? Is it premium matters? Is it benefit scheme matters? Or plan type matters, or something? So that's the one thing that you can do by linking this plan characteristics file to MBSF file. And if you don't have a really separate question about the plan characteristics themselves, then you could at least control for plan characteristics as a covariates in your regression model. So even without having any specific questions related to the plan type, I often request the plan characteristics file and use the plan type as covariate in my regression in any model. So plan characteristics file consists of 6 sub-files. So if you say plan characteristics file, and you actually see 6 different files in that. So the key file here is plan benefit base file. I used to call it simply base file. So this base file, plan base file, includes probably most information you might need for your study, including plan type or benefit schemes. But so we're going to spend the most of time in this discussing this plan-based file, but there is a separate premium file, as you can imagine. That's premium information is there. And you have a cost sharing tier file, cost sharing information is there, and service area file, and you can actually see, what's for each service area, how many plans are actually operating there, and for each specific plan, and what service areas that the plan offers. So that's a service area file, and there is a crosswalk file, and then there is a separate special need plan contract files. SMP, the SNP, contract files has become available in 2015. So you will see before 2007 and 2014, you will have only 5 sub-files. So one thing to pay attention working with the plan characteristic file is unit of record, because that differs across all these sub-files. So and then you have to link these files and also link these files to PDE or MBSF or sometimes A and B files and etc. So you have to really pay attention to unit of record and then clearly identify the merging keys. So the first plan benefit base file. So this base file includes information on plan type and drug benefit information. So now here the unit of record is contract plan. So contract plan, this always go together. And in the morning, Becky's section, right? Becky mentioned that you always want to actually concatenate these two variables and then use these two variables together whenever you merge. So what is then contract and what is this plan benefit the package? So contract is an entity that enters agreement with the CMS. Enters a contract with the CMS, and this entity organization says that, hey, I want to participate in Part D program. Let's suppose United Health. United Health serving in the operating in Minnesota. They said, well, Part D program came in, so I want to provide Part D plans and Part D policies. So they enter contract with the CMS. So then they get assigned this contract ID. So this is a unique ID. So the first letter of contract ID indicates organization type. So for United Health, it's because a local MA local managed care plans, it's going to begin with H. So this is United Health assigned the number H0000. Actually, it looks like H3405 or something, probably 4 numbers after H. And then, so now United Health now have a contract, and then it's just thinking, oh, wait a second. So what kind of plan benefit package do I want to provide? So first, you could think, oh, well, we have this standard benefit package, right? That specified by Medicare Part D, and said, okay, so we're going to create one policy or one benefit package that exactly follows the standard benefit scheme. So the deductible and pre-ICL, ICL, and catastrophic coverage, fine. But then these are insurers who are doing business. So when they do business, they're thinking, what? How can we attract more beneficiaries, right? So they want more beneficiaries to enroll in their plans. Then think, well, wait a second, do really Part D or Medicare beneficiaries would like, deductibles? I think that they probably might prefer some benefit package that does not involve any deductibles. So they decided to remove Part D, and then they began some co-payment structure, right? So if you're taking generic, $5. If it's brand name drugs, let's say $50 or 20% co-insurance. So they modified their benefit scheme a little bit. Then whenever they modify their benefit scheme, they get assigned, that becomes a new policy, new plan. So this H3333, this United Health has now 001, that's a plan ID. 001 is the standard benefit. And then they have a 002 that does not have any deductibles. And then 003, where, that let's suppose before the donut hole was closed, and they're thinking, well, we want to provide a more enhanced benefit that has some coverage for the gap. And that policy becomes the 003. So really you can identify when we say Part D plan, it's really a combination between this contract ID and plan ID. So, and then by looking at the first letter of a contract ID, you can actually see the organization type of that specific Part D contract. In that case, contract plan. So first level of contract ID indicates organization type. So H is local managed care organizations. And R is local, meaning that their service area is defined based on county. So the managed care organization might serve only one county, but they might serve multiple counties and several counties. But the unit is county. Region, that's why that's what this local means. Now, R is represent the regional PPOs, and PPOs are preferred provider organizations. So what is a regional? Regional is either it's one state or more than one state. We have about more than 30 regions in the nation. So it's like 33 or 36, I'm not sure. So one state, Minnesota might represent one region, but the Nebraska or the South Dakota or North Dakota, this, for example, 3 states might represent one region. So this means the regional PPOs means that you have to serve all the areas in that region. So if the regional PPO count doesn't provide any information, because the regional PPO Minnesota, that means that, oh, this PPO serves Minnesota, entire Minnesota. Oh, the regional PPO that serves a little bit the other side of the Midwest. Oh, North Dakota, South Dakota. Oh, they are all in this region, and they serve all the areas in that region. That's regional PPOs. Standalone PDPs, as we saw, that this is what the traditional fee-for-service, traditional Medicare fee-for-service in beneficiaries enroll to have a Part D coverage. Now, the contract ID starting with E is employer direct contract plans. I want to really emphasize here, this is a direct contract. Does not necessarily include all employer sponsored plans. So E represent employer direct contract plans. And I will come back to here when I discuss EGWIPs later. And then X is a LINAP we discussed earlier. And then H also represent some other types of managed care organizations as well, not necessarily managed care organizations, some other types of plans, whether it's a demonstration project or whether it's a national PACE plan or it's a cost plan, and they are also starting with the H. Now, then you could probably ask, hey, come on, how do you know that whether when you say the H, whether this is a local or whether it's others? That means that there are other variables that indicates more specific organization type, right? So now, because we covered now contract ID versus plan ID, you can guess that always the number of plans in each category is greater than number of contracts, right? So contract is a little bit higher level, United Health and HXXXX. And then that contract offers different types of a benefit package or different plans, right? So we have a more plans than the contracts. So that's H. So a lot of the Part D plans are either MAPDs here, the local MAPDs, or standalone PDPs. And we have some regional PPOs. Employer direct contracts are very few. There are only 3 employer direct contract plans, and they have 4 plans, which means that one contract offers 2 different types of a benefit package and 2 plans. And then we have some H. See, how did I distinguish this H versus this? And how could I put this 190 plans to this category as opposed to this 672 plans that went to local managed care plans. So you have to look up some other variables, right? So we have a variable, these are all variable names. We have organization type, plan type, demo type, and EGWIP. This is EGWIP indicator. And then we have indicator for special need plan, SNP type. So in this organization type variable shows the local MA, in other words, the local managed care plans or regional PPOs and PDPs, employer direct plan and national PACE. And you can select out this national PACE and cost plans. Then plan type is, and if you are local MA plan, your local managed care organizations, still they can be HMOs or local PPOs or private people service or something. So this plan type has additional information. And then demo plans, it's a demo type versus it's not demo plan, and EGWIPs and SNP. So let's look at what this EGWIP is. And there was some question in the morning. I learned from this workshop that this is called employer group waiver plan, and it's called usually EGWIPs. So this EGWIPs indicates employer sponsored Part D plans. So EGWIPs, they are not required to submit any benefit or tier information. So you will not get to see benefit or tier cost sharing information for EGWIPs. some EGWIPs do have a PDE data. I think it's more and more we see PDE data from EGWIPs, but not sure. In earlier days, I found some more cases where we couldn't identify PDE data for EGWIPs, but it seems like more populates more these days. And now another thing to keep in mind is that not all EGWIPs are employer direct contract plans. So which means that these EGWIPs, what is this EGWIPs? This is EGWIP, yes, right? Yes and no. Oh, if you see the first letter of a contract ID of these EGWIPs, you will find a lot of H or S, which means that some are MAPDs and some are standalone PDPs. So SXXX, but still it's EGWIP, and this is HSXXX, and it's still EGWIPs. EGWIPs are still employer-sponsored plans, right? That starting with the E is just the only employer direct contracts. Then what are these? Who are they? They have this H or S. They are local MAPDs or standalone PDPs, and why they are EGWIPs. So when employer wants to provide Part D plans to their employees or older employees who are Medicare beneficiaries or retirees, right, who are eligible for Medicare, there are different ways of they can do that. So when first Medicare Part D Part D came in around 2006, employer were thinking, okay, so now Medicare starts cover prescription drugs. I want actually our employees, my employees to be covered by our Part D as well. Okay, so how do they do? What this direct contract means that employer, let's suppose University of Minnesota. University of Minnesota entered the contract with the CMS. So they get assigned a new contract ID only for University of Minnesota employees. That's employer contract ID, right? So that begins with the EXXX. So we saw that there are only 3 employer direct contracts, which means that 3 employers, they actually behaved like insurer, right? Party plan, party contract. But their original mission is not providing insurance coverage to University of Minnesota, it's academic institution, but they enter the contract with the CMS and then get assigned the number EXXX. That's employer direct contract. It's relatively few. Now, another way to do is that it's too much, right? So if you are employer, yes, I do want to provide the coverage, Part D coverage for my employees. However, my mission is not providing insurance coverage for my employees. I have other missions. But then what can I do? And then looking around, and University of Minnesota found that United Health, the neighbor, around there, they already got assigned the contract ID by entering, agreement with the CMS. It's HXXX. So the employer went to United Health and saying that, hey, could you create policy or benefit package only for our employees, right? You already have a contract with CMS, and you are Part D service provider. So under this HXXX, you can simply create 800 or some plan benefit package. But this plan benefit package, we don't want to mix with any other beneficiaries. This package is only for our employees, right? Then it becomes employer-sponsored Part D plan. That's EGWIPs. Of course, EGWIPs include employer direct contract as well, but these EGWIPs are here. Those who are using already established Part D contracts, but then by creating one policy specific for their employees, and they actually becomes EGWIPs, right? So when we say that, okay, how many employer-sponsored Part D plans in your data, then you have to use EGWIP information. This is a plan level information, not contract level information. So you cannot simply look at the first letter of contract ID to find the employer sponsored plans, right? So EGWIP captures all employer direct contract plans. So if you are direct contract plans, of course you are EGWIPs. However, most EGWIPs are actually MAPDs or PDEs. So in order to exclude or identify all employer-sponsored party plans, you have to use this plan level, plan-specific information captured in EGWIP indicator. Okay. This is important because oftentimes every year, probably most of you already know Kaiser Foundation, you know, Kaiser Family Foundation or MedPAC, they produce annual report, and they always have the number of party plans. So when you get the party data, first thing you want to do is that you want to check your numbers against those reports, right? And then you come and say that, oh no, well, in my data there are so many contract IDs. I have like 80 contracts. No. I have let's say I have 43 contracts, but I have 3,000 PDPs. I have 6,000 MAPDs and etc. But what you're missing here is that you have to really look at carefully the notes of a table from MedPAC reports or Kaiser Foundation reports. They oftentimes, usually almost all, they exclude the PACE, demo, cost, employer. They simply say employer, but this is employer sponsored plans. All EGOWIPs are excluded from this table. And LINET or an SMP or Part B only plans. So in order to make really to do apple-to-apple comparison to follow the MedPAC approach or Kai's report approach, then you have to use both the contract level or a plan specific information, and you have to use EGWIP indicator. Okay, so one question would be, okay, what type of plans that it's better to exclude in doing any research? And this is my recommendation. This is actually oftentimes almost all studies exclude this because these are somewhat unique. And the way they get paid is different, and who can enroll, the enrollees characteristics are different. So just comparing drug utilization with about general party population, between general population and the enrollees in this type of plans might be a little bit different. It might not be really fair or reasonable. So you want to exclude the national PACE, demo, cost, employer sponsored plans, Part B plans, and linear plans. And these we have all the indicators in plan characteristics file. I did not include this special need plans here. Earlier days, they always MedPAC always excluded SNPs, special need plans, because there is only a small number of SNP plans, but now it's increasing so fast. There are a lot of D SNPs or C SNPs or I SNPs. So I would actually, rather than excluding SNPs, I would actually create a separate table or a separate analysis for SNPs versus non-SNPs. It's just my recommendation. That's a plan type, information about plan type. And then another piece of information in this, again, we are with a plan benefit base file, right? And the base file, you can get the benefit information, right? So the first, there is a variable called the drug benefit type, and this variable tells you whether it's a defined standard. This is Medicare defined standard benefits. And also some plans are called actuarial equivalent. What does this mean? This means that it has defined deductibles like as the same as a standard benefit. However, they modify the cost sharing structure. You might not see co-insurance. Instead, you may see co-payment after deductibles. Another plan type, benefit type is called the basic alternative, and this type of plans have modified deductibles and or have a modified cost sharing. And then enhanced alternative means that they provide more generous benefits than standard benefits, right? So in the before ACA or IRA period, the top sort of enhancement in benefit, it was that coverage for the gap, coverage for the donut hole. But these days, donut hole is closed, and then you may actually see the coverage for the additional drugs or lower cost sharing, no deductibles and etc. This is a descriptive pie chart for the type of drug benefits. So what do you see here? So these are PDPs and these are MAPDs. So PDPs, about 61% has enhanced alternatives. I'm going to move this here, right here. That's better. Yeah. So this is about 62% of PDPs have enhanced alternatives, and here, but in MAPDs, 97% of MAPDs have enhanced alternative. Wow. right? And you can see that the MAPDs provide a more generous drug benefits, right? And also you can see the plans based on the deductible types, and there is a standard deductible, and then some plans have a reduced deductibles and smaller deductibles than the standard, and then some plans have a zero deductibles. And you can see here where is the zero deductibles, and these gray ones. So only 14%, 13.48% of PDPs have a zero deductibles. However, in MAPDs, more than half of MAPDs had zero deductible plans. And here again, we excluded all these special types of plan type. Right. So that's about base file. So just the base file gives you information on plan type as well as benefit, little benefit information. And these are probably the most information that you want to use, or the somewhat important information that you want to actually look at in plan characteristics file. Now, there is a file called cost sharing tier file. So what is a tier? So standard benefits, if you think about Medicare standard benefits, it has deductibles and 25 co-insurance, and then donut hole, which is gone now, and then catastrophic coverage. There's nothing on tier. So what is a tier? That tier is a Part D plans. So instead of using this standard benefits, what they were thinking is, well, we want to create some tiers and then place a specific type of drugs in there. So for example, in tier 1, we identified really preferred generic drugs. I really want to steer our enrollees to use more of these preferred generic drugs. And then they put all those drugs that they like, their enrollees to take, that it's a tier 1, and then they charge really low copayment. Let's say zero copayment. If you are taking preferred generic drugs, it's zero copayment, or $5 copayment, etc. And then they create a second tier, tier 2. They might actually place now. It's still generic, but not necessarily preferred or non-preferred, or just the generic drugs. And then copayment is a little bit higher. Tier 3, preferred brand name drugs. Now it's copayment is $50 or 20% co-insurance. So they created this tiered benefits, and then by placing certain type of drugs in a specific tier and then making this cost sharing different across tiers, they want to actually steer their enrollees to use some specific types of drugs, right? And so that information, that kind of how they create the tier, how much they charge, and that type of information is all in this cost sharing tier file. So then what is the unit, what would be the unit of record in this file? That's contract plan tier. Think about it. So contract HXXX001, tier 1, 2, 3, 4, 5. So then for this tier, how much? And you can find that information in this file. So for each specific tier, contract plan tier, you can see what types of plans are covered in the tier. It's brand versus generic, or there may be a little more detailed categories in types of drugs covered, and then whether cost sharing type, whether it's a copayment or co-insurance, and then amount. So if it's a copayment is checked, then you will see dollar term. If it's a co-insurance, you will see percentage. It's a cost sharing amount. So, and in addition, this type of information is available for each different benefit phase. So plans might, I don't know how frequent is that, plans may create different tier structure depending on benefit phase. That's possible. So you can see this tier information by benefit phase, and even within benefit phase, for example, pre-ICL, also this tier information, the cost sharing particularly, that differs based on the days supplied. If you are filling the 1 month or 3 month or other days, and also type of a pharmacy, whether the pharmacy is in network, or it was a mail order, or it's a preferred pharmacy or a non-preferred phamarcy, you receive different types of cost sharing. So it has really, this is a master file that if you are interested in cost sharing. So now, okay, do I really need to use this tier file? Do I need to learn about this? So what can we do with this using tier information? So one thing you can do here is that, okay, using information on drug type and cost sharing, you can actually examine, and we can actually get, okay, how much the cost sharing difference between generic and brand name drugs, right, for each plan. Then you can examine, oh, is there any relationship between copayment amount and the use of medication, particularly to say use of a brand name medication. So for in this examples of Plan A, this Plan A used the tier to second tier to place preferred brand name drugs. And then they charge it, I'm going to just use pre-ICL benefit phase, and this is an in-network pharmacy, and this is for 1 month of medications that they just apply, and this plan uses a copayment, and this was $50 for preferred brand name drugs. Plan B used the third tier, tier 3, to place preferred brand name drugs, and then for the same benefit phase, pre-ICL in-network pharmacy, 1 month of days supply and 1 month of supply, and then copayment, and it's $100. I'm going to look at where enrollees in Plan A are. I would hypothesize that they are more likely to use brand name drugs compared with Plan B. So actually, we did some analysis. So we did some study. We picked up the MAPD only. This is a small study, MAPD only, that who used the study in 2008, and then we actually constructed all the copayment for preferred brand name drugs for each plan, and then our dependent outcome variable was indicator of a filling prescription with a brand name drugs. These are all statins, the branded statins. And then you can see here as copayment goes up, odds of a filling prescription with a brand name, it goes down. When $1 increases, the odds of a filling the prescription with a brand name decreases by 2%, right? Okay. And also, we controlled for plan type, but this is somewhat interesting. This says that compared with the private fee for service, enrollees in HMOs are less likely to fill the prescription with the brand name drugs, which makes sense. These are HMOs, but PPOs are actually more likely to fill the use of the brand name drugs compared with the private fee for service. So you can do this type of a study if you can actually play with cost sharing tier files. So since I'm talking about this tier, I want to mention this specialty drugs in Part D. So specialty drugs, in a simple way, this is expensive drugs. A lot of biologics or new drugs that has high cost, then we call them as specialty drugs. So in Medicare Part D, they define specialty drugs as drugs that has monthly cost is greater than $830 in 2022 and 2023. Used to be only $670 in 2021. Before that, it was only $600, I think. Right. So as long as your monthly cost is greater than $830, now these drugs are you can designate them as a specialty drugs. Now, if they are specialty drugs, you can place those drugs in a specialty tier, which is called a specialty tier. Specialty tier is where specialty drugs are placed, right? And then, so once the tier is defined as a specialty tier, and you can actually charge a little bit higher cost sharing, up to 33% co-insurance than other tiers, but you have to offset this higher cost sharing for specialty tiers by lowering deductibles. And that's some condition, but then you can create a specialty tier. So a lot of the Part D plans use 30 to 33% of co-insurance for drugs in specialty tier. And some plans actually didn't use a specialty tier, but then I found some plans that they create the non-preferred non-preferred tier, and then actually charged up to 45% co-insurance. That was a little bit interesting case. Now, but anyway, so with this, you can think of, okay, then how many plans are actually using specialty tier, right? And in 2021, this is a 2021 data, and we found that this about 93% of Part D plans had a special tier. This actually increased a lot. When was it before? No, I used the 2009 through 2013 data. This wasn't the case. Special tier, not many plans had this one, but then really starting with the Sovaldi, actually, that was actually that opened up new era, sort of a new age for these high cost drugs. And around 2013 and 14, a lot of biologics and new drugs came up with a really high price tag. And then this use of specialty drugs are now norm in Part D. And so what tiers they use for specialty tier, you can find that information in cost sharing tier 5. So that's a cost sharing tier file. And then there is another separate file called the premium file. And this premium file includes premium information, of course. And then here, what is a unit of record? Unit of record is a contract plan segment. Oh, what is a segment? So once you have a contract plan, this means that you have exactly the same benefit package, right? Plan ID represents the benefit package. So you have a same benefit package on the same contract, same organization, but you have a segment, which is a county actually, but you have a different premiums. Segment is a county, and this is covered by particular benefit package with the another next neighborhood segment. However, their premium is different. And this applies to only to local MAPDs. So you will see for majority plans, it's like a 99% of contract and plan ID, they don't have a segment. But about 1% of MAPD records has one more than one segment. So you will see contract ID, plan ID, segment ID 1, 2, or 1, 2, 3. And these type of plans actually account for about 1% of MAPD record. Doesn't sound really fair that you have exactly the same benefit package, but why more expensive than my neighborhood, right? It depends on the Part A and B payment system. So if you understand how MA plans gets paid from Medicare, then you can see that how they actually play with this. But I'm not sure. I have not used a lot of segment information. When I get usually my unit of analysis is a contract plan. So when I want to get the premium, I simply get the average premium across a different segment, and I just make this file as contract plan level, and then just do analysis. But again, that's a researcher's discretion, and it depends on your research question. Okay. So here, this table shows average Part D total premium by benefit type and by deductibles between PDPs and MAPDs. And you can see that premiums are higher. So it depends on probably the benefit type. It's a little bit different. I cannot say, but on average, we saw that in the morning that premiums are usually lower for MAPDs than PDPs, but here it's not clear when we broke this down by benefit type and deductibles. But here, another one interesting observation here is that this is not typo. So you have MAPDs, they provide enhanced benefits, but their average premiums is actually lower than the MAPDs that has a benefit package. But this is true. This is because they have a lot of payment margins from Part A and B side, and they cross-subsidize from Part C side towards Part D, so they can lower premium for enhanced benefit packages. Right. The next file is a service area file, and here for each benefit package, you can see what service areas they serve, right? What areas they serve. For the regional PPOs, you may see regions, and standalone PDPs, you may see state. It's local managed care plans, you will see probably county. So unit of record is contract plan service area. So for service area, for local MAPDs, you receive county. And then for regional MAPDs, regional PPOs, you receive region. And as well as a state, because one region might include more than one state. And if it's a standalone PDP, you receive state in the service area. And then from here, one question in the morning, the really plan availability differs across the different service areas. Yes, and you can get the plan availability from this file. Right. The next file is a plan crosswalk file. Plan crosswalk file is really tracking over time, the contract ID and plan ID over time. So sometimes you want to identify enrollees who remain in the same plan for the 2 years or something, right? So, or consecutive years, and or for 3 years and 4 years. So you want to use a contract ID and plan ID you want to track. However, some contract or plans, they are exactly the same plan and same contract, but they change in numbers. So this file allows you to get whether these plans to identify whether these two contracts and plans between 2011 contract ID and plan ID, 2012 contract and plan ID, whether they are the same plan or not. And this is oftentimes this is useful because when they change their numbers, plan ID numbers, or when they consolidate, if there is M&A going on, you still want to say that, and this plan was merged into this plan into 2012, and you can follow that, oh, they're still in the same contract or same plan. And there is an additional relation code that says C, that means it's consolidated, N is it's a new contract, new plan, R is it's renewed, and T is terminated. When something disappears, you can see, oh, is it because of termination or is that because of consolidation? And that's what this crosswalk file tells you. Right. So in summary, so using this plan characteristic file, how do we want to use a plan characteristic file? And you can use this files as a standalone source, and you can examine how many plans are available to beneficiaries in specific areas, or what percentage of party plans have a deductibles, or how premium differs across different plan type or benefit package, and how much they are different, of course, right? And also geographic differences in plan availability and premiums as well. Now, and also that's a standalone news, and this is a really good information. You can produce some interesting information there, but by linking now. When you link this plan characteristics file to MBSF file, you can see the enrollee characteristics across the different plan types or plan benefit packages, and also you can actually develop some party plan choice model, and if you're really interested in doing some economic research, and you can see the impact of the premiums on plan choice. Is this really premium the major determinant of beneficiary plan choice? Always pay attention to the unit of record or identifiers. So when you merge these two different files, the plan characteristics file with others, so what variables do you use? So plan tier files, you will probably use contract ID and plan ID. And also, while premium service area, you might actually use a segment as well. But if you actually aggregate into some level the premiums, then you can use our contract ID and plan ID. Right. So finally, and by linking this plan characteristics file to PDE files, of course, you can examine all the medication utilization or party drug cost by plan type and benefit schemes, and also whether beneficiaries who are in catastrophic coverage, who hit the catastrophic coverage, does it vary by a plan type or benefit scheme or anything. And also when you use the PDE files, you may want to actually aggregate PDE file. PDE file unit of record is an event, right? To aggregate to beneficiary level, because plan beneficiary level has one contract ID and plan ID, right? So so always, this is one example that you have to really do some pre-work before you merge to ensure that the correct merge.